Hey there, micro friends. Welcome to another episode of Let's Talk Micro. As always, I am so happy that you're here with me. And if this is the first time you're listening to Let's Talk Micro, well, thank you for choosing it as one of your podcasts. Okay, so let me briefly tell you what this episode is about before we jump into it. We are diving into intestinal parasites and global health, focusing on a study from pediatric patients in Guinea, West Africa. And in this episode, I'm joined by a friend of the podcast. He's been a guest many times before, who's Dr. Joel Mortensen. And he joins us to talk about the real world challenges of diagnosing parasitic infections in resource limited settings. He also goes over what the data from the study revealed and why seasonality, microscopy, and rapid tests matter more than we might think. Such a great episode, so let's go ahead and listen to it. Hey, micro friends. Today we are talking about parasites, and I also get to talk to a person that he has been a guest in the podcast before, and it's always great to see him and talk to him. So we're gonna talk about a study that was done from a patient population in Guinea. So with me today, I have Dr. Joel Mortensen. Dr. Mortensen, welcome to Let's Talk Micro.
Louis, it's wonderful to be back. Thank you. I've enjoyed both listening to all of your podcasts, a fun collection of interesting and different areas, but I also enjoyed the last couple of times we've been able to talk about the work that we do in Guinea, West Africa.
Definitely, it's always a pleasure, talking to you. So once again, thank you for accepting my invitation. So for those that are tuning in for the first time, maybe you can start with like a quick introduction about yourself and what your background in clinical microbiology is.
Sure. So I joke. It's actually a standing joke here that I've been doing this a long time, and in fact, some of the people here think I worked with Louis Pasteur. I remind them that that was 1847, and that I'm not that old. But I've been doing microbiology for 40 years now. So it's been a long run, and I've got to see a tremendous number of changes. So right now, I'm a professor here at the University of Cincinnati at the School of Medicine, and I direct the diagnostic infectious diseases testing laboratories at Cincinnati Children's Hospital.
So yeah, definitely. I always say this a lot in the podcast. Even in the time that I have been in, 10 plus years, we have seen a lot of changes. So can't even imagine, 40 years. So let's go ahead and start talking about this study. So what motivated this study on intestinal parasites in pediatric patients in Guinea, and why was it an important question to address?
So let me just set a little bit of the background with the hospital in Guinea. About 3 years ago, we opened the first pediatric hospital in the country of Guinea. And it's hard to get my head around that even to this day that there was nothing in the country for specialized for pediatrics. Um, there are units within the bigger government hospitals for neonates and for pediatrics, but nothing dedicated. So my goal was to set up a laboratory that balanced the state of the art here in the United States, what we think is best care, with the available resources in West Africa. And I think it's difficult to imagine just how different it is. So you're right, I've seen a lot of changes in 40 years, but in fact, the microbiology in Guinea takes me back even before when I started microbiology on how basic and the limited resources that we have there. But I think we've made some nice progress in the last couple of years. We've got a number of technologists. We're able to do some good basic testing. I have to tell you that most of it focuses on a very short list: malaria, Salmonella typhi, diarrhea, and sickle cell anemia. Because, as we've talked about before, 100 out of 1,000, so 10% of children don't make it to the age of 5 in Guinea. It's a shocking number. And what do they die from? Malaria, diarrhea, sepsis, and sickle cell anemia. And so beginning to address those diagnostically and with therapy has been the challenge and is really what we're continuing to do there as we improve the service. So right now we're seeing about 70 patients a day. We've got some US trained physicians, but also a number of locally trained physicians, and the country does not train pediatricians. So their medical schools have nothing in pediatrics. So we are the training center for the country for physicians for pediatrics as well, which is, again, mind-boggling to me. The best of those go out of the country and train in some neighboring countries that have pediatrics to be able to come back. So I spend about 6 weeks a year in Guinea working with them, and then we spend a lot of time in between on the phone with Zoom calls when there's power and the Wi-Fi is up and running and we can do a Zoom call. So your question to me really was then, what motivated the study? A couple of things. One, anything that you can imagine doing for research in Guinea has never been done before. So literally you can ask any question. How common is Staph aureus? How common is E. coli? What's the anything that you ask has never been done in Guinea. Publications are very thin, and when they are done, they're done by methods from the 1930s or 40s as we would view them in the US. So what I wanted to do is begin to introduce the laboratory and the medical staff at Sacré-Cœur Hospital with the idea of what does research look like? How do you design it? What are the purposes? What impact does it have? And I think it's an important question because we see a tremendous number of children with diarrhea, as I indicated, and we have no real diagnostic test. So we're just basically what happens is you send them home and say, if it's still going on in a couple of days, come back. And then we'll pick out some antibiotics or something and we'll try them, which seems like insanity to me. So we don't have cultures yet there. So I thought, well, what can we do with what we have? And we'll talk about it a little bit more, but microscopy is the basic stool exam there. And that's direct exam. So it's stool with some iodine under the microscope. And we're looking for big ova and worms, which there are a fair number of both of those. But because we're not capable yet of doing permanent smears for a variety of reasons, including we don't yet have fume hoods and things there. So I don't want to expose the workers to the chemicals used for doing permanent stains. It's difficult to get some of the supplies, so we've got that sort of challenge. And most of the patients come in for one visit and then go home. They might come back again. But so we want something that we can diagnose right now. And permanent smears would be tomorrow or batched the next, depending on the weekends. It could be days later. And so we tried to think about what would benefit right now and set a new precedent for doing research in this unique setting. So that's what drove us to do this particular study and try to answer the question about diarrhea.
Thank you for that, and for the listeners, on the show notes, I want to put the link of the episodes where the first episode that I did with Dr. Mortensen, where he came in and he talked about how he got involved in the with the hospital in Guinea, and he talks about the training, the conditions. It was such a great, like I had listening to him, and it's something that we working in the lab, we don't think about that much. We go to a lab, we train, we have our equipment or things, and that was not the case there. So the episode, it was a great conversation, and I split it in two. So I'll put the link on the show notes so you can go and revisit it. I definitely recommend listening to those episodes. Okay. And before I ask you a little bit more about the study, since we kind of talked, and and you talked about the training and things like that, I remember from our conversations that you it's been a few years now, and if people wanted to get involved or help, they could reach you out. Is that still the case? You're still looking for people to help out, or how are things going? In the present time with that.
Sure. Well, again, going back to the fact that we've established that I'm old, um, I'm looking for people because this is going to be a long-term process. And so Dr. Morgan Pence from Cook Children's in Dallas now is alternating with me. So she's spending time in Guinea and supporting as well. I'm taking infectious disease physicians with me in March this year to try to begin to build these bridges. And so I'm absolutely interested in people who are willing to go and put boots on the ground, both to learn, but also to contribute on how we can do better and better, because I don't have all the answers. So getting those input is always valuable. You can look up Sacre-Cœur for the website, or you can reach out to me, and maybe you can put this in text, but Joel Mortensen at gmail.com. And I always love to hear about people and their interests and what they think they'd like to contribute.
Perfect. So I'll go ahead and put that on the show notes. And as I always tell listeners, if for some reason, if you're not checking the episode or something pops in your head and you feel like you want to contact Dr. Morrison, you can also, email me at letstalkmicro@gmail.com and I will happily forward your information as well. So let's talk about the study. Maybe you can walk us through the design and the findings.
Sure. Um, I guess maybe before we get there, let me give you a little bit more context because I think it's interesting and important, because intestinal parasites are really a global issue, and we forget that sometimes in the U.S. because we don't see such a burden. Any of us who do international adoption, though, you can see children from around the world bring a host of parasites. So it's a worldwide problem, and most of that is affecting school-age children. And the studies are fascinating depending on where you are and the studies in different parts of the world. As many as 50% of the children in a study can be positive for an intestinal parasite at any point in time. And it's not just once in their lifetime, it's again and again and again. So, according to the World Health Organization, 1.5 million people are infected with intestinal parasites. 500,000 people have severe illness, and almost 200,000 people a year are thought to die from some kind of parasitic intestinal infection. And in the subtropics and tropical regions, which is that big swath through the middle of Africa, infections are endemic. They're a leading cause of death and disease. And it's not just death and disease, but among children, for example, less than 5 years of age, diarrhea is linked to poor growth, impaired cognitive development, along with mortality. And it's the low and middle income countries, especially in sub-Saharan Africa, Central America, China, and East Asia, that are most impacted. And so one of the interesting things that we'll talk about in the study design is, as I said, it's not just an infection once and they're cured. They're constantly exposed. They're constantly coming back with the next infection. And it's hard enough with bad nutrition, but then you're competing with a parasite for that nutrition. So they're constantly struggling. And in fact, I often have to be cautious with children there because I can't guess their age by their size and their apparent development because they're small, they're undernourished. And we know that that affects their development in their brains. And so the impact, I think, is tremendous. So let's move on to the study. We sat down and we said, how do we best design this to capture the data so we understand what we call point prevalence, but what's going on at this slice in time? And there's two basic seasons there, hot and wet, hot and dry. And so we weren't sure, but we thought maybe they're different because when there's so much rain, sewage and fresh water are all mixed together and the rivers are spilling over. So we thought maybe there's a difference. So we did two slices in a wet season and a dry season. And then we combined the basic microscopy that they're quite good at because they see a lot of positives with a lateral flow assay that's made actually outside of the country. So it's made in Spain. I contacted the company and they felt sorry for me. And they were very helpful and gave me a fabulous price on a cartridge-based lateral flow assay that does Giardia, Crypto, and Entamoeba histolytica. So all three in two strips in a single cartridge. So to be statistically significant, we wanted to make sure we had enough representation. So we took 200 sequential patients. We looked at their microscopy and then their lateral flow results. We do have a local IRB, but we didn't dig too much into the person's data as much as just looking at the point prevalence. So we designed that to do 200 sequentially, essentially in June, and then 200 sequentially in November, December of that same year.
Okay. Maybe you can talk a little bit more about you talk about the hot and wet and then hot and dry. So, what are some of the differences that you observe between samples collected during the rainy season versus the dry season?
Well, we'll talk about results in a second, and I can really point out the differences. But just looking at the process, the wet season, as I said, we know that the water systems are a mess. We get more patients in the wet season because in addition to more diarrhea, there's more malaria. Tremendous amount of malaria in the rainy season. And I was telling someone the other day that I always try to sit at the bench and read malarial smears with the technologists. One, to help them out in the rainy season, but two, to prove to them that I can sweat right next to them and do the same microscopy that they do. But by myself, I was averaging 10 new cases of malaria a day. And the other technologists are doing what they're doing. So out of those 70 patients that we're seeing that day, 20 of them could be with malaria, and the next 10 or 15 with diarrhea. And then in the dry season, it really is, there's no rain. In fact, getting water at all is somewhat problematic. Malaria goes down, diarrhea goes down, and we don't see nearly the number of patients. But what happens is the malaria shifts a little bit. There's a little bit more vivax, and the kinds of infections we're more likely to see, probably the same number, but we're more likely to focus on Salmonella typhi, sepsis, meningitis, and some of those more classic infections. It's also easier to travel in the dry season than the rainy season. So we think that we get patients from further away when they can travel. I don't have real data on that, but it felt like they were able to get to us easier, and so they could come from further distance.
Okay, and by now, you have talked about this, and then we'll I'll be asking about the results, but can you talk more about some of the biggest challenges of diagnosing intestinal parasites in resource limited settings?
Sure. Because that's where I've been living. We're used to having microscopes, right? We have Nikon or Zeiss or something, and in a big lab like mine here in Cincinnati Children's, we may have across the lab we may have I don't know 15 microscopes, right? So true story. When I first visited, we visited another laboratory because ours wasn't set up yet, and they had just gotten an electric light source for their microscope, so that they didn't have to use the mirror and try to catch the sun through the window to use their microscope. And they were old, and they were broken, and the optics were terrible. And that was in a true commercial laboratory, just getting a basic microscope. So I shipped two from the US, one brand new and one donated, Nikons, that were expensive, but one of them also has a camera so that they could take pictures and send them to me if they had questions over the internet. So the number one challenge is a basic microscope. Cover slips, they're hard to get. And every now and then we have cover slips and they stick together and you just throw them out, right? You just pitch them. They were used to saving the microscope slide, not the cover glass, but the microscope slide. They would save them and clean them and reuse them. So basic supplies. And in fact, when I went back the second time, I said, now we're not reusing slides anymore. They said, no, we're not reusing slides. I said, well, what's in that bucket over there? Oh, well, those are slides, but we're going to save them and clean them and give them to the hospital down the road. No, that's insanity. I'll bring an extra box of slides that we'll give to the hospital down the road, but just getting those basic supplies. The next biggest challenge is the education of the technologists. So one of the key technologists in the laboratory at Sacré-Cœur is a woman. And you sort of go, well, that's half the lab is women, right? Or more maybe here in the US. No, what you have to realize is that the majority of the women in Guinea don't go past the third grade. Esther got to what we would call community college, or 2 years. She has a 2-year college degree in laboratory medicine. Shockingly unique. But even that education is good, but the way they're taught is nothing like we're used to here in the US. And so their basic education is a constant struggle. And in fact, I spent months just teaching laboratory practice, lab safety, they wanted to wash the slides, they wanted to rewash the gloves. They're just not used to basic things that we're used to here in the U.S. And our goal there is to be compliant with the CDC, I'm sorry, the WHO standards that are used throughout Europe. So basic equipment and then education. And that's just doing microscopy. As soon as we begin to talk about cultures, blood cultures, we need incubators, we need refrigerators. Well, sometimes 6 hours out of the day, there's no power. So now there we have a generator and we have solar panels and battery backup so that at least the laboratory and the pharmacy can be cool and have power all the time. So the basic infrastructure can be abysmal. Buying bleach to clean with. It's hard to find bleach? Yes. So those basic challenges, and let's say, for example, we wanted to get some positive samples from the hospital down the street. They just gave me a blank look. Well, they've never shared. They're not cooperative. That's a different hospital. What? And so building this idea that we see in the US, because I don't know about you, but we do it all the time. We run out of blood plates, so the hospital down the road gives us a box and we replace their box, right? They had never heard of the concept. So those are some of the basic challenges that we faced just getting it up and running to begin to look for our parasites.
Yeah, that's something that's so right, so common here. It's like, okay, well, we ran out of media, as you said, or some Vita cards. So let's see whose hospital is around and check if they can lend us some, and then we'll borrow some. Wow, these are some a lot of challenges, and there's some things that maybe we don't even think about here in the lab. Some all the way from basic supplies to training. Wow. Um, while we're talking about now we talk about resources, but let me ask you a little bit about the testing. So when it comes from a lab perspective, what are the strengths and limitations of traditional stool microscopy compared with antigen-based or rapid test?
Yeah, I think that's a great question because that's one of the questions we faced. So as I said, it's very easy and they have a lot of practice with a basic slide, stool, iodine cover slip. And they can look for large things under 40x. And I'll tell you those numbers in a second, but that's easy and straightforward. We can do malarias there, but the difficulty in doing a permanent stain is one, you make a smear, well, you collect it in formalin PVA or some combination. So those have to be smeared and dried and then stained and then looked at. So there's a time delay that's a particular challenge there. So the direct microscopy was easy, but we haven't yet worked out how to do permanent smears. So the next best answer, I thought, was to look at the lateral flow technology. I also think there's some real limitations with sensitivity and specificity, because you need a lot of education to differentiate some of those individual amoebas that we might see in a stool if we're doing permanent smears. But in resource limited settings, everyone's used to doing HIV, hepatitis C, some basic lateral flow tests, sickle cell testing. There's a lot of lateral flows that are made throughout the world. They're easy to ship, they're easy to QC, they're easy to handle, and they can be stored easily. And so getting lateral flows, the assays there is basically easier, cheaper than trying to do a traditional permanent smear. And we may yet get to permanent smears there, but for now, lateral flows offers the advantage of at least as good as or better sensitivity and specificity. Now, microscopy can identify probably 50 different things, and a lateral flow can't. So one of the things we wanted to establish is how common are the common things. And so combining microscopy and the lateral flow help us to try to establish, are we looking for the right things or do we need some lateral flows for some different things? And I think you'll see that Giardia crypto entamoeba histolytica from the lateral flow perspective captures a mammoth amount, a large amount of the organisms that we're interested in.
Okay. So what can you tell us about the findings of the study overall?
Sure. So the patients that we saw ranged from 1 month to almost 30 years, but most of them were 7 years old. Is the mean, and the median was 7. We tested slightly more males than females for no particular reason other than I think it's just statistically a little bit different. But what we found was that the rainy season and the dry season are different. So if we looked at what we saw on microscopy, the differences were much less. But we saw schistosoma mansoni, and I don't know how many stools you've seen with schistosome in them, but in the first 300 that we did in the rainy season, we saw 12, and in the dry season, we saw 14 in the very short period. We also saw strongyloides, hookworm, ascaris, Hymenelepis nana, and my favorite was Balantidium coli, because before they stained it, we looked at it under the scope, and you could see the Balantidium coli swimming. Coolest thing in the world, a ciliate swimming in the stool. I'm sure the patient wasn't as happy to see that as not, but and the only real difference between the rainy and the dry season was that ascaris was more common in the dry season, and I don't know why. So that was the basic microscopy that we then wedded to the lateral flow. And the lateral flow was much more striking between the two seasons, in that Giardia was the number one. In the rainy season, nearly 30% of the patients, we had 205 that we ran, 200 that we did during the rainy season for Giardia, almost 30% were positive for Giardia of patients who walked in with some kind of gastrointestinal complaint. In the dry season, it was only 14%, clearly different. Entamoeba histolytica was 10% in the rainy season and only 1% in the dry season. And Cryptosporidium was 15% in the rainy season and only 3% in the dry season. So to me, the two seasons are strikingly different. Again, we think it's having to do with rainwater, sewage, and potable water or drinking water because they're kind of all mixed together. But we were also struck that 30% of children walking in off the street with some gastrointestinal complaints, 30% had protozoa, on top of the 7 or 8% who also had the various worms and Balantidium coli, making it almost 40% of children. In addition, and I didn't, we don't need to get too lost in all the numbers, but a number of children had more than one protozoa. Some of them had all three at one time. So how did that translate? Well, the clinicians, one, were shocked because metronidazole covers most of those protozoa, not the worms. So they would give them worm medicine, but never thinking to treat protozoa when almost 3 times as many had protozoa as had worms. So we've started already just empiric therapy for treating diarrheal disease with metronidazole, based just on the clinical study that we have so far. So I think those are the big findings from this preliminary study. But remember now, this is almost 400, almost 500 children total that we had microscopy and lateral flow. So I think it's real numbers, and I think the seasons are different, and the doctors need to look at their patients differently depending on the time of the year.
Okay. And this, because I know, like, I looked at it in preparation for this episode, and has this been published already?
Well, we have an abstract that we submitted to the American Society of Tropical Medicine and Hygiene that we presented at the most recent meeting in Toronto. And you might find this mildly humorous. In Toronto this year, there was blinding blizzards. So the sign for the tropical medicine meeting is covered in ice. And almost 60% of the people who come to this meeting are from resource-limited settings. So these guys from Africa are in Toronto, and they don't own winter coats. They were just suffering terribly. But anyway, we presented it at that meeting and got a very nice reception. We have submitted it for publication to the American Society of Tropical Medicine and Hygiene to their journal. It's been in there a month waiting for review. Hopefully soon we'll hear back. But I'm confident that this is a unique and interesting study that will be published.
Yeah, definitely. Um, so how can data like this, realistically inform patient care, public health planning, or prevention strategies in regions like Guinea?
Yeah, I think that's an important question, because you might ask, well, do you run this test now on every patient? Well, no, we don't yet. Why? Well, there's a couple of reasons. One is I haven't figured out yet, and when I go back in March, I'm going to work on this problem, but I haven't figured out how to get the test from Spain into the country. And you go, well, that's crazy. You just give it to FedEx. There is no FedEx in Guinea. There's no DHL. There's no post office. So I've got to have a distributor make arrangements to ship it into Guinea, and then the distributor can sell it to me. Okay. Supply chain is shocking there. The other problem is our goal is to have a laboratory test cost $1 to $2 for each patient. And we got a very good price on these lateral flow assays from Spain. I think we paid $5. And lateral flows here in the US, I pay $12 or more. And maybe if I drive it down to $3 even, but that's still expensive for a family. And we talked about this once before, where they take up a collection in the village when the family comes to the hospital so that they can maybe buy some food and pay for some tests. And so, I've told you this. I pay my interpreter there. Yes, my French is terrible. I pay my interpreter there really well. I pay him $10 a day. So if you imagine, here in the US, what do I charge for a blood culture? $50, $60, nobody blinks. Yeah, that's not possible there. And so we've got to figure out how to have a cost-effective way to test and treat an individual patient. But as I said, the clinicians now are aware that 30% of their patients in the rainy season, if they come in with diarrhea, 30 to 40% of them will be, well, 10% will be a worm and 30% will be a protozoa. And so based on that alone, we can judge empiric therapy with just the direct microscopy for the worms to rule out that part and drive empiric therapy. It also then is a clear statement to public health that this is water. It's water, right? All of it. And so that, we hope, will be able to be communicated, because there is a Pasteur Institute in Guinea, actually in Conakry. I was there the last time I was in town, and I was so excited to visit a Pasteur Institute, because that's part of their involvement, is understanding the epidemiology and how we can impact public health. And so I think now we need to begin to say, we understand where it comes from, and we need to begin to look at water and how we address that.
Okay. And earlier you mentioned like asking another hospital in the area for samples and something that we think that is so common here in the US where we collaborate and things like that. So why is collaboration with local laboratories so critical for studies like this? And also what does an effective partnership look like?
So, I'm not going to talk about the downside of Guinea, but let's talk about the upside. When we physically went to visit local hospitals, they were so excited to have the conversation. What are you doing? How do you do this? This was brand new. So the answer is, we've got to do more of that so we can develop a relationship. Because the reason you can borrow from the hospital down the street and I can borrow is we've developed a relationship. And so what I've got to do in Guinea is continue to foster relationships. And in fact, although I don't like the current test that we're doing for sickle cell anemia there, one of the local hospitals had no idea how to test. And our technologists from Sacré-Cœur went to help them train. They had never done that before. So we begin to build those bridges to help them train. This last summer, unfortunately, I wasn't there, but a team came in from Dallas Children's in the US and put on a full-day seminar, I believe on emergency medicine, and invited people, doctors and laboratorians from the local hospitals within the region to come to Sacré-Cœur, have lunch, food always works, and talk to these world experts in a collaborative sit-down setting that they had never done before. So we are actively trying to be a part of the community, to share the education, to share the resources, to develop the relationships. Because, of course, the next study could be 2 or 3 hospitals. Expand the geography of what we can do this testing at, and potentially, if they don't have the resources, we can do the testing, but they bring us specimens. Now, I also have to tell you, how do we get a specimen from hospital A to hospital B? You give it to a courier who wears a backpack and rides a motor scooter. Blood samples on ice? Yep. In the backpack, in the motor scooter, and they go zooming through these dirt roads, through crazy traffic, to bring us samples. But all that can be worked out. And in fact, the other piece that's fascinating there is the Pasteur Institute there is kind of new. And they came to Sacré-Cœur and said, can you help us do serology for measles? And there were some other viruses that they were studying. And my response was, well, of course. We do that all the time in the US. Public health, we share samples, they collate them, do the studies. So I think collaboration with the Pasteur Institute and hopefully the government's a little harder to get to, but clearly our colleagues in the Pasteur Institute are interested, and each time we expand the circle, we expand the power and the validity of the study.
Yeah, well said, Alan. And when it comes to actually with studies, what future studies do you think are needed to build on these findings?
Sure. So we're doing a couple of interesting things. One, there's a device built for sickle cell anemia separating the red cell types. And it's not my world, but it's a device designed for resource-limited settings that we've taken there to begin to try to improve the diagnosis and screening for sickle cell anemia. But in my world, my next question was, well, I've accounted for 30% and some worms. That maybe it's 40. I've still got 60% of my diarrheas. I don't know what causes them. So I got to figure that out. So what's next? Pick a virus, right? What's the incidence of rotavirus? That's an easy EIA to run. What else could we do? Norovirus, Astro, a variety of others. Might be a molecular method, not a lateral flow, but maybe a lateral flow methodology that we can begin to expand just stool microbiology. Beyond that, I don't have blood cultures there yet. When we think they have Salmonella typhi, bacteremia, we give them ceftriaxone and hope. So and what I'm trying to bridge there is those are studies and yet they're clinical applications either for empiric therapy or our next innovation in testing. And so I want to make sure we keep aware of what does the study do? It's not just an interesting academic exercise, but it's what is applied directly there. And if we can't necessarily bring the test, will it help us understand the epidemiology and what to do with it? So viruses are next on my list. I got to begin to understand what makes up that 60%, not just my 40.
So definitely still a lot of work ahead. And when it comes to this, is there like a key takeaway that you want clinical microbiologists to remember from this work?
Well, I think what I want the world to hear is what healthcare is like there. Because malaria, as an example, or diarrhea, is preventable. Sickle cell anemia may not be preventable, but not having sewage in your drinking water is preventable. There's a vaccine and mosquito nets and ways to address this public health because there's millions of people, at least hundreds of thousands in the case of diarrhea, but they're dying every year under the age of 5, and it's completely preventable. And our expertise is key to how to innovate and educate and eventually eliminate or at least limit this incredible disparity between what we see in the US and Europe and what most of Africa is experiencing. And I tell people, one of those little children who didn't make it may have been the next Albert Einstein, and we lost. We can't. It's a ridiculous waste of potential. And even some people in business begin to realize that there's a market there. I mean, the size of Africa, if we can raise the standard of living so that they can go to work instead of staying home with malaria, imagine the things to be sold, the processes to have. Even if you just want to make money, you need people that are healthy. And we can have an impact. Now, I'll tell you that people have told me, well, Joel, you can't fix all that. You can't. Like, it's insurmountable. No, it's not. We can fix it. And what I do and what I can do is to continue to try.
Yeah, yeah. Wow. Well, definitely thank you for all the work you do, and I think that's as the episode starts coming to an end, and I like to end up with a question that's kind of like a light question, and I like finding the answers. But before I do that, is there anything else that as we come to an end that you would like to tell the audience, either about this or about anything else?
Yeah, I think sort of building off of what I was just saying, I think one of the things that all of us here in the US healthcare system, you don't have to go to Africa to be involved, right? Because most of the people can't. I am unique in that I have 40 years of experience. Um, I have financial resources. I can take off the time. I have all those things. I don't have a family any longer, so I can do all these kinds of things. But we can all be involved in United to Beat Malaria, in support for the CDC, for WHO. We can all be involved in the world around us, not just stuck in the little microsphere of wherever we're living or working at the moment. We can lift our heads up and be involved without necessarily being to be physically there. So there's always ways to participate, to donate, to contribute if we lift our heads and look at the world around us.
Right. Well said. So, yeah. And as we said earlier, if you feel if you feel you want to contribute in any way, you can either check the email address on the show notes and contact Dr. Mortensen. You can also email me as well, and I will happily once again, forward your information. And of course, if you have any questions about how physically being there, you can do that as well. And I'm guessing that it's you mentioned about resources, so that will be like on a like a volunteer basis, right? So you have to like self pay for your cost to get there.
Yes, some of my faculty colleagues have funds within their divisions, um, but but essentially, again, we don't really understand it in the U.S. There are no resources. I mean, if I told you what I pay for an airfare, you'd be shocked probably. But the idea that a well-paid medical technologist makes $3,000 a year there, well paid, my airfare is much more than that. So there is no resources. So yeah, it's volunteer. It's a choice.
Okay. Well, for this last question, I always like hearing about the answers. I get some different answers. It's a way to end up the episode like on a lighter, fun note, people have for many reasons, right? They either have a favorite bug or they have a least favorite one too. It could be because either very common is that they work with it in school, but it could be anything, right? Anything from the mechanism, the way it looks, or for many reasons, people have either their favorite bug or their least favorite bug. So, Dr. Mortensen, what is your favorite bug?
That's a great question because, yes, when I did research, I worked with Staph aureus. I've always had a soft spot in my heart for Staph aureus. But my new favorite is the Balantidium coli. It's like a big fat paramecium swimming through stool with all of its little cilias. And it has a little pore where it feeds, and so you can see it rotating itself to try to find nutrients as it's swimming around. I've never seen anything like it. And I remember studying it, years ago in school, and you're going, yeah, that's weird. But to be there and watch it, how it's adapted to living inside of a human host while free living at this, I was blown away by that interaction between the parasite and the host. So thanks for that question. That was fun.
Yeah, my pleasure. As I said, it's always great hearing the answers. And one thing as you were talking, and then a lot of us like microbiology, right? We really like what we do, and we bring a lot of passion to it, and it's really great to see that you still have so much passion to for what you do. After so many years. So thank you for that. I always enjoy talking with you. I had the good fortune of have met you in person a couple times already. So, but thank you for the work you do, and thank you for being here in Let's Talk Background.
A pleasure as always. I hope to bring something else interesting for you another time.
Perfect. Definitely yes. Always, anytime you want to come in and talk about something, we're here. So thank you. Well, there you have it. That was the episode. I hope you enjoyed it. As always, it's such a pleasure chatting with Dr. Mortensen. So thank you, Dr. Mortensen, for taking the time. Okay, so I invite you to check out the show notes where I posted the links for Dr. Mortensen's previous episodes, where he talks about the lab in Guinea. And if you feel that you can contribute in any way to this, I have included Dr. Mortensen's email address. You can also email me, and I will forward the information on your behalf. Okay, so as always, you can find us on any podcast platform. So if you go to Apple, Spotify, Amazon Music, Good Pods, we're right there. So I invite you to subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. Thank you so much for the support. You can also follow us on socials on Instagram, TikTok, YouTube, and Blue Sky Social. We're there as Let's Talk Micro, on X as Let's Talk Micro 1, LinkedIn as Luis Plaza. There's the website, letstalkmicro.com, and an email address, which is letstalkmicro@outlook.com. And either via social media, via email, you can leave any feedback, any suggestions. They are always welcome and appreciated. So besides subscribing to the podcast, I invite you to subscribe to the website where you can find, licensing information, study resources, episode updates, and more. If you want to support us in any way, you can do so via Venmo or via Buy Me a Coffee, KOFI, both links available on the show notes. As you know, learning about antibiotics can be difficult. So if you're looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, micro friends, it's the end of this episode. I hope you enjoy learning about the study, learning about the challenges of diagnostic testing for parasites in Guinea, West Africa. As always, I enjoy sharing this information with you. And stay tuned. Great things, great content coming your way. So please continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.